Good evening, everyone. We'll wait for a few more minutes to let the others join and then we can start. I guess we can start. Can you guys, am I audible? Can you hear me? Anybody? Am I audible?
Yes, ma'am.
Okay, thank you. Let me just share my screen. So good evening, everyone. Welcome back to week 7 of the NPTEL online course Drug Delivery Principles and Engineering, and we have been discussing some previous year assignments. So let's begin with the topics discussed in week 7. I'm assuming some of you must have gone through the lectures. If not, we'll just go over a quick recap. So we have been discussing about concepts in drug delivery followed by tissue engineering, and in the last week we saw certain questions associated with implant associated infections. In this week, for week 7, the theme is route specific delivery, where the professor has discussed various routes of administration, and depending upon our application, what drug we want, that's where our route specific delivery comes into play. So for example, if you have a patient and you don't know which route to go ahead with, then that question depends on certain factors, such as, first of all, depending on the application. For example, if your patient has a skin injury and there's a skin infection, then for that you'll most probably go for a transdermal application. So depending on this, wherever your injury is, wherever you want your drug to be localized, that's where that is the route you'll decide. Next, it also depends on the physiochemical properties of drug. For example, if you have chosen the oral route of delivery and you want to give the drug orally, but then you come to know that the drug will quickly degrade at acidic pH. So whenever you're giving drugs orally, it will go through this gastrointestinal tract and through the stomach, where the pH is very low, very acidic, and that's where most of your drug will be lost. So then for this specific patient, you have to give a different route of delivery. And also it depends on the dose you're giving. For example, if you have intramuscular or subcutaneous dosage, then the volume of dose is very limited. So if you want to give a lot of drug, then the best route will be oral route. So going ahead, the lecture discusses about oral route in detail. Various drug delivery systems for oral route are available, like you can formulate your drug into a tablet, a syrup, or a capsule. The advantages of oral route is it's highly patient compliant, non-invasive, but the disadvantages are first pass metabolism. I hope you guys remember from some of our initial discussions what first pass metabolism is. So most of your drug, when you take it orally, it gets metabolized in the liver, and most of it will be lost there before it even reaches your site of action. So that's the first pass metabolism. So most of the drug which will be given orally will be lost, and then it also undergoes degradation in GI tract, like I already said. So these are some of the disadvantages, and in the lectures, if you have seen, the formulation of an oral drug is discussed in detail, where certain factors such as the drug, the excipients used, the binders used has also been discussed. Next, for oral route, you can design the drug as a form of controlled release dosage. For example, there's something known as osmotic tablets. This also, I guess, we have discussed in one of our previous sessions, where you have a tablet and it's formulated like there's a small hole in that tablet, and whenever you administer this orally, water will flow into this from the small hole, and it will have, so because of osmosis, the drug will slowly then be released out of this tablet. Then we have something known as enteric coatings, which we'll be discussing in detail because it's one of our questions for this assignment, this week's assignment. And there's also something known as bioadhesives. This also we'll discuss. So next, going ahead from oral route, there is subcutaneous route. This is a parenteral route, meaning it bypasses the gastrointestinal tract, and it's injected. So subcutaneous is, the layer is right below your skin. So that's where you inject your drug. So the advantage is it bypasses first pass metabolism, so you can actually save a lot of your drug from going to the liver. But the disadvantages is it's invasive, because the patient has to be injected the drug into the body, and if the patient is not trained, then somebody else, the medical official, has to do this. And another disadvantage for subcutaneous route is only a maximum of 2 ml of drug can be injected. So that limits the amount of drug which you can administer. Next is intramuscular route. Similar to subcutaneous, this is also a parenteral route. The advantage, so intramuscular is below the skin layer, you will have your muscle layer. That's where you inject your drug. So the advantage is similar to subcutaneous. This will also bypass your first pass metabolism, which is a good thing. But again, it's very invasive. Actually, intramuscular injections are very painful, and specific training is required to administer drugs intramuscularly, because it's difficult to identify the muscle layer, and if patients want to self-administer it, they have to be trained in that. And going ahead for this week, the last few lectures are discussing about the transdermal route, that is just above your skin, through the skin. So the advantages of this route is it has a local effect and it can be easily administered, it's non-invasive. The disadvantages are only a very low dose can be administered. Also, low molecular weight of drugs, the drugs which can be administered through transdermal route, they need to be of low molecular weight because you have a layer of lipid layer in the skin, so it does not allow higher molecular weight drugs to permeate. And also this area is very prone to immunogenic response. For example, even if, let's say, an insect or a mosquito bites you, you can immediately feel the immune reaction happening there. The area gets red and it gets swollen. So it's very difficult to administer drugs through transdermal route because of this reason. But we can enhance the delivery using certain chemical and physical methods that also we'll discuss in details. And then lastly, the concept of microneedles was discussed, which are formulated with certain polymers, and you can inject these microneedles into your skin, but care needs to be taken that you don't harm the patient in this process. So these are the points discussed in this week. Anybody has any doubt in this, or we can move towards the assignments? Shall we go ahead? Am I audible?
Yes, ma'am.
Okay, sure. So I'll go ahead with the discussion of the assignment. You guys can stop me whenever you have a doubt. So this is the first question. Which of the following is not a parenteral route of drug administration? And there are two correct options. If anybody wants to volunteer, you can go ahead, or else we'll discuss.
Oral and rectal, ma'am.
Oral and rectal. Anybody else?
Oral and rectal, ma'am.
Yeah, thank you. So yeah, that's a pretty easy question. So parenteral essentially means the route where your drug administration into the body is done by bypassing the gastrointestinal path. So all of the rest of the options, intradermal, subcutaneous, intravenous, intramuscular, nasal and intra-articular, all of them will bypass your gastrointestinal path. Only the drugs that are administered through oral or rectal route has to pass through the gastrointestinal path. Is this clear? Okay, let's look at the next question. So the next is, what are the two most important sites for drug elimination? And these are your options. Anybody?
Kidney and liver.
Kidney and liver.
Okay, thank you. Others? Okay, let's look at that. Both of you are correct. The right answer is kidney and liver. So this was there in very initial lectures. If you guys have gone through the week 1 lectures, so I've picked up the slide from that presentation. So these are the various routes of elimination of drug from the body. So the major ones are kidney and liver, but drugs can also be eliminated from the body via minor routes such as lungs and sweat and salivary glands. So the correct answer for this question is kidney and liver. Okay, let's move towards the next question then. So the next is, which of the following routes of administration has the least bioavailability for an acid labile drug?
Oral.
Oral, okay. Any other guesses?
Oral, ma'am.
Okay. Do you guys have a reason for that? Do you guys want to volunteer of why oral is the right answer? Anybody wants to give an explanation?
Because, madam, when we given the drug in the urine, the
Okay.
drug may be inactivated by the acidic pH which is present in the stomach.
Yes.
So, because of this, the availability of drug in the blood will be less.
Right.
So that I am doing this answer.
Yes, you're absolutely right. The correct answer is oral, and your subsequent explanation was also correct. So, bioavailability, as you guys might remember, is the amount of drug that is actually available to for its action whenever it's delivered in the body. So, bioavailability depends on the route of administration. If you are giving the drug through IV route, that is intravenous, you have 100% bioavailability, because all of the drug that you have been injected is injected in the blood, and then it's available to go all over the body and to its specific site of action. So whenever you give drugs through oral route, as you might have seen in this particular slide, whenever you give drugs through oral route, first of all, it will be cleared out, most of it will be cleared out by first pass metabolism. But whenever the drug reaches the GI tract, that is through the stomach and intestines, because of the acidic pH, there are high chances that your drug will be getting degraded there. So as per the question, which of the following routes of administration has the least bioavailability when your drug is an acid labile drug? The correct answer will be oral, because since it is an acid labile drug, most of it will be degraded in an acidic pH, which is found in the stomach. So from the given options, the only way the drug can reach that acidic pH is through the oral route. Everybody else will bypass the GI tract. Is this clear? Let me know if you guys have any question. You can stop me at any point and we can discuss. Okay, let's look at the next question then. Next is, which of the following mechanisms are not commonly used for permeation enhancement in transdermal delivery systems? Anyone?
Surgery.
Sorry?
Surgery.
Okay. Any other answer? Thank you for answering. Okay, let's discuss the answer. Yeah, you're correct. The right answer is surgery. So for transdermal delivery, as I said, it has, whenever you're giving your drug transdermally, it has to go through a lot of layer of skin, which is mostly a lipid layer, dead cells layer. So to enhance the drug permeation, we have certain chemical and physical methods. So first of it is the chemical enhancers. For example, you might have seen whenever you go for an injection, you might have seen doctors just apply ethanol over your skin. That is mostly done to sterilize that area. But also ethanol is a very good agent to have lipid permeability. For example, similar like ethanol, you have certain other agents like DMSO and oleic acid. So they just destabilize this lipid layer and they help your drug to permeate inside the skin. But care needs to be taken that you can't increase the amount of this DMSO or ethanol, as it can be toxic to the body as well. One other method is making the drugs as prodrugs, because as you know, lipids are they are hydrophobic. So if you make your drug lipophilic, that is which can interact with the lipids very easily, then it's easier for the drug to pass through that lipid layer. Another method is bombardment, where you use something known as gene gun or powder jet, and you shoot these smaller particles. Remember, these particles are in the range of micro or nanoparticles. So shooting these particles into the epidermis, that is the upper layer of the skin, it's not actually harmful. You won't feel any pain, but it will give the extra push for the drug particles to go inside the skin layer. Another method is ionophoresis, where you apply small electrical current for a long duration, and because of the application of this electrical current, it will cause ionic changes in the lipid layer, and this will destabilize the lipid layer. It will create gaps in this lipid layer, and then your drug can easily permeate inside. Similar thing happens when you electropore it. This is a high voltage applied for a very short duration, taking care you do not shock the patient with the high voltage. Another method is using ultrasound, where you use cavitation forces by giving sound waves to the skin. They are at a frequency where it will again destabilize your lipid layer, and then the drugs can permeate. Another method is photomechanical energy, where you give similar in the case of ultrasound, where you use sound energy. In photomechanical, you can use laser energy to disturb this lipid layer and thereby increase the drug permeation. So the question is, which of the following mechanisms are not used for permeation enhancement in transdermal delivery system? The right answer is surgery, because surgery is not used for transdermal delivery. Is this clear? Okay, let's move on towards the next question then. Next is, what kind of a drug is not a good candidate for transdermal delivery? And there are two correct options.
Option A and D.
Option
A and D.
Option A and B. Okay, low partition coefficient and high partition. Okay, is not a good candidate. Okay, any
High
other?
molecular weight, ma'am.
Yeah, so the right, you're saying it's low partition coefficient and high molecular weight.
Yes.
Okay. Anybody else? Okay, let's look at the answer. Yeah, you're correct. The right answer is low partition coefficient and high molecular weight. So for transdermal delivery, as I said, this is what your drug has to go through if it's given through the transdermal route. So you see, you have a lot of lipid layer here, which is formed by the dead keratinocytes, that is the dead skin layers, skin cells. So whenever you have a drug, if it's of a very high molecular weight, it will be difficult for the drug to pass through. Similarly, if you have a drug which has a low partition coefficient meaning it's hydrophilic, it has more solubility in water phase compared to lipid phase. So if you have drugs which have low partition coefficient, it will be difficult for them to pass through this layer. On the other hand, now if you have a drug that is of a low molecular weight, it will have a low size, so it can easily permeate through these gaps. Similarly, if you have a drug that has high partition coefficient, meaning it is lipophilic, it can interact with the fatty acid layer, the lipid layer very easily, then it can easily pass through this transcellular route. So the question is asking us what kind of drug is not a good candidate for transdermal delivery. So the right answer is, if it has a low partition coefficient or if it has a high molecular weight, it will not be a good candidate to go for transdermal route. Is this clear? Any doubts in this question? If not, we'll move ahead. The next question is, enteric coatings are likely to release drugs at, and we have to pick two pH options, the correct pH. Any guesses?
Last two options, ma'am.
Sorry?
Last two options. That is pH is greater than 11 and pH is greater than 8.
Okay. Thanks for answering. Anybody else? No other response? Okay, let's look at that. Yeah, you're correct. The right answer is at pH higher than 8 and pH higher than 11. That's when the enteric coatings are likely to release drugs. So let's look at what enteric coatings are. So this is basically a thin film of a polymer or any other material that is used over the solid dosage form of a drug. For example, if let's say this is your drug molecule and then you have coated it with a polymer. Now you choose the polymer in such a way that it has a lot of carboxylic acids. So for if it has a lot of carboxylic acids, and if so you basically you're doing this enteric coatings to prevent your drug to be released into the stomach, and you want that drug to be released in the intestinal part. So this we are doing because as we know, in stomach it has a highly acidic pH, and a lot of drugs have a tendency to be degraded at acidic pH. So we don't want to lose our drug in the stomach area, and we want the drug to be released in the intestinal area. So to do that, you coat this drug molecule with this enteric coating which has a lot of carboxylic acids. Now in the acidic pH, whenever you take this drug orally, it will reach the stomach where the pH is very less. So at this low pH, all your carboxylic acids in the polymer will be protonated, meaning there will be COOH form. They will not protonate, and as a result, those molecules, because it is in the COOH form, it will have low solubility because it's not charged. So because it is having now low solubility, most of your drug will be intact inside this polymer layer, and the polymer layer will not allow your drug to diffuse. So whenever this drug molecule is in the stomach, it will you won't lose much of your drug. Now when the drug molecule passes from this acidic pH in the stomach to the intestine where the pH is somewhere around 8, most of the carboxylic acids in this polymer will be deprotonated, meaning it will lose their H+. So now your COH will be of the form CO minus and H+, and being ionic, now they will have a very high solubility. Because of the high solubility, this polymer layer will be dissolved and your drug will be exposed to the intestinal layer where it can now act. So in this way you provide this enteric coating to your drug to avoid its release in the stomach, and you can release it in the small intestine. Is this concept clear? So according to the question, the enteric coating will release the drug only when it's at pH above 8 or 11. That's the pH of your intestinal tract. Clear? Any questions? Okay, if not, I'll go ahead. Next question is, the first barrier that is encountered with transdermal delivery system is. We have to name that barrier. I just flashed the slide, so anybody knows the answer?
Option stratum
Second
corneum.
option. Okay. Anybody else? Okay, no other response. Yeah, you're correct. The first layer of the skin after giving your transdermal delivery of the drug is the stratum corneum, which is made up of this lipid layers. So pretty straightforward question, nothing much to discuss here. Next question is, the major problem of transdermal drug delivery route is. We discussed some of these points. Any answers? Basically the disadvantages of transdermal drug delivery.
Maybe that second option, ma'am. Small doses administration is only possible.
Okay. One more?
And the drugs with molecular weight more than 1000 daltons cannot be given.
Right, you're correct.
Because more molecular we cannot able to give, no, madam.
Yes, you're correct with both your options are correct. So this is the major problem with transdermal drug. We can only give small doses because the skin does not have much area to hold your drug. So that's why only small doses can be administered. And as you correctly said, if you have a high molecular weight drug which is higher than 1000 Dalton, it will not have enough so it will have a smaller, if you see this layer, if your drug is bigger of a higher molecular weight, it will not be able to pass through these layers, and as a result most of your drug will be lost, will not reach the site of action where it's required. So these are the major disadvantages of the transdermal drug delivery duct. Okay, next question is, which one statement is false for bioadhesives? Any answer? Okay, no response, we'll discuss. So the false statement for bioadhesives is chemically bonded bioadhesives are most highly recommended, which is not the case. So bioadhesives are again a polymer layer over your drug, which you do so when you want to slow down the transit time of your formulation. For example, if you've given a drug through the oral route and you want that drug to retain in the stomach area for a longer time, or in the upper intestine, gastrointestinal tract, then what you can do is you can coat these drug molecules with certain polymers, which will then form a bond with the mucus layer that is present when you give a drug orally. So because so you can have this polymer layer over the drug which has certain functional groups which will have adhesion to the mucus layer. So by doing this you can slow the transit time which your drug takes. Usually it will be flushed down the gastrointestinal tract. So these bioadhesives can have chemical bonds, or it can have mechanical or physical bonds with the mucus layer. In chemical bonds it can have covalent interactions, it can have hydrogen bonds, or it can have van der Waals interactions. And in mechanical or physical bonds it can physically entangle with the polymer of polymer and the mucus. So you coat your mucus usually has a lot of these proteoglycans which are extended polymer chains. So whenever you have your drug and you coat it with a polymer, so these polymers will entangle with the polymer chains in the mucus, and then your drug will be retained at that place for a longer time. So even though you have the option of these chemical bonds over the drug molecule, you can have covalent interaction, but there is a problem with this. Since you are changing the drug molecule, your drug is now having a polymer coating, it can have lesser biocompatibility, it can give rise to immune reactions because you are changing the drug molecule. So it's not advisable to have covalent interactions, rather you can rely on the mechanical or physical bonds. So according to the question, which one statement is false for bioadhesives? It can chemically bonded bioadhesives are most highly recommended, which is false statement because it's actually not recommended. Is this clear? Any doubts in this question? Okay, then I'll move on towards the last question of the session. The last question is, which one of these is an advantage for oral administration? Any answers?
Ease of administration.
Yeah, pretty straightforward. That is the only advantage an oral administration gives you. Rest everything is a limitation of oral administration. When your patient is unconscious, they cannot take this drug orally. In that case, an IV route is best preferred. Also, low solubility drugs cannot be administered because they will not be absorbed through the GI tract and most of your drug will be lost. Also, drugs with lower permeability cannot be administered. Again, since they have lower permeability, they will not be absorbed through your intestine. As a result, it will have low concentration in your plasma, and the drug won't be available for its required action. Also, it can be degraded by the GI enzymes or flora present in the stomach. The only advantage of oral route is ease of administration. Food interactions is not an advantage because your drug can interact with the food you have taken, and that can change the pharmacokinetics. That can also affect its activity. And then the most prominent disadvantage of oral route is the first pass metabolism. So the only advantage here is ease of administration. Clear? So we have almost reached the end of the assignment. Are there any doubts? Or if anybody has joined late and you want me to discuss any other question, we can go over the assignments once again. This seemed like a pretty easy one this time. Guys have
Yes,
any
ma'am.
doubts? No doubts? Okay, thank you.
Thank you.
Yeah.
Can you quickly discuss?
Sorry?
Can you discuss it quickly? I joined just now.
Yeah, sure. Let me just flash it once again. Yeah, we can quickly go over the assignment. Yeah, so the first question was, which one of the following is not a parenteral route of drug administration? The answer was oral and rectal, because everything else is parenteral. Parenteral means drug administration into the body where you bypass the gastrointestinal path. Next question was, what are the two most important sites for drug elimination? The answer is kidney and liver. Everything else is the minor. So by every other route, the drug can be eliminated, but the major ones that are responsible for drug elimination is the kidney and liver. Next was, which one of the following routes of administration has the least bioavailability of an acid labile drug? The answer was oral, because when you administer a drug orally, it has to go through this GI tract and ultimately through stomach, where the pH is very acidic. So if your drug is very, very acid labile, it can degrade in this acidic pH, and it won't be available. It won't be absorbed in the bloodstream, and it won't be available for its action. So hence it will have the least bioavailability when it's given orally. Next was, which of the following mechanisms are not commonly used for permeation enhancement in transdermal delivery system? The answer was surgery. So whenever you are giving your drug transdermally, it has to go through this dead skin cells and a lipid layer. So to enhance the delivery whenever given transdermally, we have several methods such as chemical enhancers, making a drug more lipophilic, or bombarding the drug through gene gun, or you have ionotophoresis and electroporation, where you apply electric current to help destabilize this lipid layer, and then your drug can permeate through this layer, or you have ultrasound or laser energy. So the only way which is not used for permeation enhancement is the surgery. Next was, what kind of drug is not a good candidate for transdermal delivery? Again, as I said, for transdermal route, it has to pass through this lipid layer. So if your drug is of a very high molecular weight, it won't be able to pass through these gaps. Also, if your drug has low partition coefficient, it will be less lipophilic, it will be more hydrophilic, and then it will be difficult for the drug to pass through this transcellular route. So the question was, what kind of drug is not a good candidate? So if your drug has low partition coefficient or high molecular weight, it is not a good candidate for transdermal delivery. Next was, enteric coatings are likely to release drugs at? The answer was at pH above 8 and 11. So enteric coatings are these polymer coatings over the drug, where you use enteric coatings to prevent your drug being released into the stomach, where it can get degraded. So what you do, you have your drug, you coat it with a polymer which has a lot of carboxylic acids. So at acidic pH, all of these carboxylic acids will be protonated, meaning of COOH form. And when the drug then passes, so because it's COOH form, it will have low solubility, and then it will pass from the stomach to the small intestine, which has a higher pH, approximately 8 or above. And at this pH, your COOH will be getting deprotonated. It will be CO minus and H plus, and now because it's ionic, it will be highly soluble, and that's when because it's soluble, this polymer coating will degrade, and then your drug will be ready to be absorbed. So the enteric coatings are likely to release drugs at pH above 8 and 11. Are you still there?
Yeah.
Yeah, okay. So the next question was, the first barrier that is encountered with transdermal delivery system is known as the stratum corneum. This was available in the slides and the lectures. Next, the major problem of transdermal drug delivery route is small dose administration is only possible, and drugs with higher molecular weight cannot be given, because there is a limit to what your skin can hold. So you can't give dosages above 10 mg per ml. And also if you have a very high molecular weight drug, it won't be able to pass through this transdermal route. Next was, which one statement is false for bioadhesives? The answer was chemically bonded bioadhesives are most highly recommended, which is actually false, because bioadhesives are again a layer of polymer over your drug, which you now use to retain the drug in specific parts of the body. Like if you are given the drug orally and you want that drug to be retained in the upper intestinal tract, then to slow down this transition, to slow down the drug getting flushed out very easily, you use bioadhesives. These are polymer layers over the drug. So you formulate them in such a way that it will interact with the mucus whenever given orally, and it will bind to that layer, and it will just stay there. Your drug molecule will stay there for a specific time and then slowly be released. So if you have chemical bonds to your drug, it can affect its activity it can affect the activity of the drug. So chemical bonds are not recommended. Covalent interactions are good, but they have questionable biocompatibility. Again, they can give rise to immune reactions. So one false statement for bioadhesives is chemically bonded bioadhesives are most highly recommended, which is not the case. Last question was, which one of these is an advantage of oral administration? So amongst the options listed here, the only advantage of oral administration is ease of administration. It is very patient compliant. Everything else is actually a limitation of oral administration. Is this clear?
Yeah, thank you.
Okay. Welcome. Okay, then I'll end the meeting. Thank you.